So let's take a look at the postictal state. So we said this is following the seizure where the patient's muscles relax and their breathing becomes labored. But again, sometimes this can be better because maybe in their general seizure, they weren't breathing at all. So some type of breathing might be better than nothing at this point. This is when it would be safe to go ahead and provide ventilations if you need to. It was not safe previously as we don't want to hold the patient down or injure them in any kind of way. But during the postictal state, we can do that as long as they are tolerant. Now, the patient might be really confused and they might even be combative during this period, so your safety is definitely a concern. These patients may present with hemiparesis or paralysis on one side of the body, lethargy and confusion. They might have weakness or they might have tingling in one side of the body. If the patient's condition does not improve, we want to consider other problems like infection or hypoglycemia. So that can definitely be a concern if hypoglycemia especially is what caused the seizure and their blood sugar was already low. You burn through quite a bit of sugar as your body is actively moving and seizing like that. So you could have used up what little stores you had left. So that's a real concern and a need for an ALS provider to be able to administer that glucose intravenously. Other causes of altered mental status, as we said, could be hypoglycemia. They could have symptoms that mimic stroke, and they could have seizures from this as well. It could be delirium, which would be a symptom, not a disease. So delirium is just a symptom of an underlying disease. And this presents as a new complaint where the patient has maybe outbursts, they're very upset. And depending on what the cause is, it could be reversed with proper treatment. So if the patient has an underlying psychological condition, ALS may be able to administer medication specific to these cases that can help with this. It could be an unrecognized head injury. It could be that the patient is severely intoxicated. They could have other psychological disorders or medication complications going on, or even infections, and that could be especially involving the brain or bloodstream. Looking at sepsis, urinary tract infections for our older population are one of the most common causes of altered mental status. So think about that for someone if they're over around 60 years old and they have unexplained altered mental status, even without the other signs and symptoms that we would historically think of for a urinary tract infection. The altered mental status could be what leads us to believe that's what's going on. So looking at some patient assessment tips and tools here, we're going to look at stroke assessments. So some of the most common are going to be the Cincinnati PreHospital Stroke Scale, the Los Angeles PreHospital Stroke Screen. We're going to talk about the FAST Mnemonic and what that means, and also look at the Glasgow Coma or GCS score, because that's really important. We've talked about what GCS is before, but putting some actual words and findings with those numbers and not just taking a shot in the dark at what an approximate GCS is going to be really important. So first, let's take a look at the Cincinnati PreHospital Stroke Scale and what does that mean. So this was obviously developed in Cincinnati, and these are looking for three things, and that's facial droop, arm drift, and speech. And there's an example video of this in this week's video folder as well, so I encourage you to take a look at that and see how this is actually done. So what you would do here to assess facial droop is actually ask the patient to smile and show their teeth, and normally both sides of the face would move equally. An abnormal response would be that one side does not move as well or does not move at all. We also want to look at arm drift. So here we are lifting up the patient's arms and asking them to close their eyes. Ideally, either both arms move at the same rate or neither one moves. But if one arm drops or drifts down compared to the other side, then that would be a positive finding, which is abnormal. And then looking at speech, you can ask the patient to say a phrase. This gives you the example, the sky is blue in Cincinnati, but most people use the phrase, you can't teach an old dog new tricks. So asking them to repeat anything that you say. If they are using correct words, then that's a normal response. But if they slur or can't repeat what you said, then that would be an abnormal finding. And so this is just one example. So let's take a look at the Los Angeles stroke screen as well. So it looks at a few of those things that we just talked about. Looking down here at the bottom, skip the top for a second, look down at the bottom. where it says facial smile and grimace. We just talked about how we can check that. Arm strength, that's going to be the arm drift. Now, one thing that is different is that this is looking at grip. And so you would have the patient squeeze both of your hands equally at the same time, just as if we were checking PMS. And if you have one-sided weakness, then that would be an abnormal finding here. Now, let me be really clear that most people use a combination of both of these. Okay, so most people will check for all of those things. They will look for facial droop, they will look at speech, they will also look for grip and arm strength. So most people will combine these two, unless your agency is asking for you to fill out a specific form and utilize a certain specific pre-hospital stroke screen, then you're most likely going to do the same and look for all of these things. Now, the reason that a lot of people have gone away from utilizing the Los Angeles pre-hospital stroke screen solely without being in combination with Cincinnati is because if you look back up at the top in those 6 questions up here, it really limits things. So again, if your patient has any of these things, then you really can't call a stroke in this age. So your patient has to be over 45 years old. If they're under 45 years old, based off of this, you would not be able to call this a stroke. If the patient has a history of seizures or epilepsy, then you would not be able to call this a stroke. If symptoms have been going on for longer than 24 hours, you would not be able to call this a stroke. If their blood sugar was outside of 60 or 400, so less than 60 or greater than 400, you would not be able to call this a stroke. Now let me back up and talk about that one for just a second. Hypoglycemia can mimic this, and I have found that out the hard way in my career, that hypoglycemia can mimic a stroke. So we want to make sure that's one of the first things that we are checking on our patient that is presenting. Even if this is textbook stroke presentation, you still want to check that blood sugar. Now, we want to be really cautious here because if the patient can't swallow, if their blood sugar is less than 60 and they can't swallow, then we don't have the option at the EMT level to provide treatment, so we would need ALS. But even with ALS, one of the contraindications for administration of dextrose is if the patient is having a stroke, because again, we don't know if it's ischemic or if it's hemorrhagic, and if it's hemorrhagic and the patient is bleeding into their brain, that dextrose can actually cause necrosis of the tissue or death of the tissue, and that's certainly not something we want happening inside of the brain. Am I right? So we need to be very cautious about this. It doesn't mean that no dextrose can be given. It just means that at the paramedic level, we're looking very closely to monitor small increments to see if we see any type of change. Now, could a patient's blood sugar be low and they're still having a stroke? Absolutely. Could they be under 45 years old? Yep. Could they could they still have a history of seizures and still be having a stroke? Yes. So this is really limiting, and that's why some people have gone away from that. So most likely you will see combination of all of these things done together whenever you're taking a look. Now let's look at GCS and what does that mean? So we've talked about this before. Remember that the highest number we can get on the GCS score is 15 and the lowest is 3. So we get 3 just for showing up, even if we're completely dead. So 15 is the best, 3 is the worst. All right, so just looking at what numbers would you assign each one of these things. So if the patient is having eye opening in response to speech, meaning you walk up and you say, hey, are you okay? And they open their eyes, that would be a 3 in that area. And if they were normal with their conversation and obeying commands, then that would still be a GCS of 14, which is technically considered altered. All right, so we want to make sure that we are documenting this very thoroughly, especially if we have any variation off of 15 with our GCS. We want to document why it was like that. How did we know? Why were they confused? Or how did we know they were confused? So just be very cautious when you're documenting GCS. Now, one thing that I did not have a picture for, it didn't come with the slideshow, but that I did want to talk about is the fast mnemonic. So I'm going to back up just a hair, all right? So the fast mnemonic, which actually comes from the American Academy of Strokes, and so this is going to be your face, arms, speech, and time. Those are the things that you're looking at. Okay, face, arms, speech, time. So what does that sound like? Sorry. Face, arms, speech, time. It's actually a Cincinnati pre-hospital stroke screen. But the fast mnemonic doesn't put it that way, because when they're telling people in the public, when they're advertising this on billboards, when they're putting it on commercials and on radios and on flyers, what they're telling people in the family is, if you see any issue with facial drooping, with arm drift, with their speech, and we need to document the time because time is brain tissue, then we need to get 911 here immediately. What they're not telling them is that you're actually doing a Cincinnati pre-hospital stroke screen. So we can help look for this and teach this to people in the public and get that message out there. The FAST mnemonic, very important. All right, so face, arms, speech, time, just something to keep in mind. All right, so let's looking at some emergency medical care here. So for patients with a suspected stroke, we need to take them to an emergency department to determine whether there is bleeding in the brain or what type of treatment they need. And so we want to take them to a stroke capable facility. And so depending on where you're located or working at will be dependent on what facility you take them to and how quickly you get there, because you also want to consider the treatment. Now, one thing that I posted in this week's videos was the treatment at Duke Health Raleigh, which was actually a thrombectomy. Now, that's still something that is being studied, and it's not available at every stroke-capable facility, but that's actually where they go in and physically remove the clot right then. A lot of times what they'll do is actually go in and administer clot-busting medications, or TXA, to patients that are experiencing ischemic strokes. Patients with hemorrhagic strokes obviously will most likely need some type of surgery to correct that bleed. So that's a little bit more intense. So we want to notify the hospital and let them know. We would call this a pre-alert for a stroke, or a code stroke pre-alert. And so things that we want to let them know at the hospital are like their last known well time. So if it was an hour ago, 2 hours ago, 10 hours ago, we need to let them know. All right. We also want to tell them what type of signs and symptoms they have, what type of vital signs they're currently having, so on and so forth. For seizures, we're looking here as far as protecting them from harm is the most important thing. We want to maintain a clear airway by suctioning, but not if the patient is actively seizing. The best we can hope for if they are having some type of vomit or secretions in the airway is going to be to turn them on their side, and we could maybe provide some suction from the side, but we don't want to jam anything into their mouth at all ever. So no spoons, no popsicle sticks, nothing in their mouth. That was an old wives' tale as far as having the patient not bite their tongue. But if they do bite their tongue, and they might, there will be a little bit of blood there, but that's about it. So we want to make sure we're not putting anything in the mouth, that we're protecting them from harm. If we suspect spinal trauma, then we can provide immobilization, but not hold them down. Okay, so keep that in mind. You can stand by, you can try to maintain C-spine the best that you can, but not at the expense of holding them down. Just because we don't want that lactic acid to be building up in the body. If your body is trying to move and you're tying them down or holding them down, that's going to cause that to build up, and that could be really detrimental. So we don't want to do that. Looking at headaches, again, we want to be concerned if the patient is complaining of a sudden onset of severe headache, a sudden headache with fever, seizures, altered mental status, or following trauma. With migraines, we can consider ALS for pain management, or antiemetics, which are nausea, vomiting medications. And we could also consider just limiting noise and lighting when possible, keeping them in a dark and quiet environment to help support and keep them as comfortable as possible. We could also administer a little bit of oxygen here, low flow through a nasal cannula, maybe 1 or 2 liters. That can help with nausea as well, and that's for any patient complaining of nausea. Looking at strokes, again, we're supporting the ABCs and providing rapid transport to a stroke center. That's what's most important, no matter what level of care you're providing, EMT, all the way up to paramedic. Rapid transport is the best that we can do. We want to try to maintain an SpO2 level of about 94%, but if the patient is not complaining of difficulty breathing, then we really want to avoid oxygen in this case, because what we know about oxygen now is that it causes vasoconstriction. And if the patient is already having issues with constricted vessels, with vessels being blocked, then we definitely don't want to constrict them anymore. So be cautious with the amount of oxygen that you're administering. Other things to consider here, again, those thrombolytic therapies, if we're within a time frame, and that's going to be dependent on the facility. So if you have any questions, you can contact medical control about that, but transporting them to a designated stroke center is really the most important thing.